Yeah, I'm good.
Okay. Tim Gilchrist is going to talk to us about big data and engagement. I've known Tim for 7 or 8 years. Besides the work he's, oh, here it is. Besides the work he does with Resolution Health as part of Anthem, he is also Columbia University and has been doing cool stuff around both data and, is it fair to say, what is actually real and what is just what we think is the data and is really just made up. That's today. And that's today. Take it away.
Thank you. So, a year ago, I was sitting with a client, and it's a big national grocery chain, and we were showing him his performance, or the company's performance, on how many people we've reached out to, engaged, brought into compliance or not compliance as health words for what we deem a healthy behavior or not. And he pointed to the corner of the room where there were a bunch of copy boxes filled with paper. And he goes, this is where I put health plan presentations, in this pile. It's like 3 feet tall. And a lot of it was PowerPoint, or it came out of a software program called Business Objects. And it's static stuff that nobody really wants to read. And we bury our clients with this stuff that they don't care about. So I started thinking on the way home about what's a better way to do this. And at the same time, there's a lot of startups now in the field of data visualization. So I started working, and I tried a bunch of different stuff, and I came up with this program called Click. It's a startup out of San Francisco. And they found focus on 2 different things: telling a story and being dynamic through this story. So you're not showing somebody just a chart. You can explore the data and answer questions live, which is really hard to do in PowerPoint. So that's what I'd like to do with you today through my hokey little health data story thing. I want to tell a story and then pretend you're clients of mine, and we can interact with the data. And the story is, I have 34 million people's worth of data collected between 2013 and now. It is designed to measure for engagement. So did they meet their HEDIS goals, which we all know about, I think, and then measuring what percentage compliance are they in, and then demographic information as well. And I've turned that into a story, and a lot of it centers around myths that I've heard through my years of working in healthcare. So here we go, and the one thing I want to say that came up before this talk was the value of data. So the claims data that we have, as Neil said, is absolute garbage. It really doesn't mean much to how you're really feeling. And if you want to get good data, you should concentrate on social media, and I don't just mean Facebook and Twitter, because when you sign up on those venues, they don't give you much. They give you really nothing. It's better to own your own. So Neil described an environment where the plan is collecting data firsthand, and then you're in complete control of what you collect. And it's much better than relying on some third party. Of course, Facebook and Twitter help you get reach in the beginning, but in the end, it's always better to own your own stuff. So one of the drawbacks with this program is it's kind of heavy on the clicking and moving things, so I'll probably have to sit down for part of it, which I hate doing, but I think it's worth it to really drive home my point in that we need to be interacting more and telling stories better. So, a little about me, and I'll whet your appetite statistically. So that's my wife and I at a place called Morro Rock in California, which is a beautiful place. My wife is a 2-time Appalachian Trail thru hiker, which means she spent a year of her life hiking 4,400 miles from Georgia to Maine. And the statistics on that are pretty interesting if you're interested in statistics. So about 95% of people who try to hike it, the trail, drop out. 50% of that 95 drop out in the first 100 miles. Of the people that attempt the trail, only about 25% are women. But if you're a woman and you attempt the trail, you're more than 70% likely to finish than a man, which is pretty wild. So,
She did it twice.
and she did it twice, which makes her a unicorn. So her excuse for finishing twice and the high percentage of women's success is that, and this is her words, women are better at suffering than men.
I agree.
So that's your little dose of my life, and as a result, we hike a lot, which might surprise you. So I started my health career at a startup called Value Health. We grew in 5 years to $1.6 billion, and then we're sold. Vestiges of this company still exist. Magellan Healthcare was started by a guy who is now president of Florida Blue called Renee Lair. You may have heard that name. And then Women's Health is another company that still exists that came out of that company, Value Health. So I spent 5 years doing that. I was webmaster of Cigna for a few years, and then same job at Aetna. And then out of Value one is seniors and those on Medicaid don't have cell phones. I listen to this all the frickin' time, and it drives me crazy. And I thought, boy, this really can't be true. So I put a picture of back in my day, cell phones were used to call people. So I took some data from the Pew Internet Research Project. They just put out a massive study about who owns cell phones. And the facts might surprise you. I don't know if any of you have ever run into that, but when you're trying to work with senior population or a Medicaid population, the first barrier that gets thrown up if you want to communicate with them via electronic devices, well, they don't do that. And I wanted to find the answer. So this is the way the Click product works. It's a little bit like PowerPoint, but it's a little different too. So if we zoom in on cell phone here, you can see the country's pretty well penetrated. We're at 98% cell phone ownership. Well, that still doesn't answer the question about the underserved and older folks. The other remarkable things on this page are smartphone penetration seems to be leveling off a little bit. And I really couldn't explain why. Maybe there's a certain threshold where people just don't need to go that extra step. Just talking on the phone is good enough. And then computer ownership is dipping a little bit. But if we cut into the data another level, we see here that ownership of cell phones, if you divide it by income, you stratify it by income, is still at 86% for people under 30,000. So if you're a family in most states and you make under 30,000, you could qualify for Medicaid. And that's an example right there where we would use data to inform ourselves instead of just having an opinion that these people don't have these devices. That yes, they do, and when you start texting people in the health context, it's extremely effective. There's lots of good studies, and I've done work with texting, that it's just a great way to get someone's attention because you're not competing with a lot of things. The mailbox is another example. When you open your mailbox, what are you competing with when you mail somebody some piece of wellness information? Bills, largely, right? So you have a good amount of their attention. Places where it's more difficult to compete for their attention would be the smartphone. That's a horrible place because you're competing with the very best minds in the world that are developing, Angry Birds and Facebook and things like that. It's much more competitive. So I would suggest then, with the data, that cell phones are a great way to reach seniors and underserved folks. So let's go to engagement itself. Now I'm going to have to sit down. So this is the 34 million data set. And the nice part about Click is that you can distill all that data and show it to somebody live. in a presentation like this and mix and match it as you go. So if we look at who spends money in this sample, which is nationwide, it includes commercial, it includes senior business and state sponsored, so Medicare and Medicaid. We see that men are spend most of the money in health, 60%. And then if we mix and match, just
I'm sorry, is that costs?
this is average spend. So in the dashboard that I've created, the average spend in this 34 million sample is $6.2 thousand in the 3-year study period.
Okay,
So thanks for asking.
all right.
So if I want to mix and match that data, I'll look at the senior spend, and we can see there it drops to 5.6K, and women start to make up some ground in spending against men. So we can work the data live if we want. One of the interesting things about these data are, if you look at primary diagnoses, so we count the number of times you've been diagnosed for some significant disease. So talking about asthma, heart disease, diabetes, things like that. For people that have never been diagnosed, the amount they spend drops in half. Okay? And you can see that there's a dissimilarity there in the commercial population, starts to outpace spending with the other senior and state sponsored. But as we climb in diagnoses, now we're at 1 primary diagnosis, we're up to the average spend. As we climb, men and women start to even out in the way they spend when they get sick. So all the way up to 5 diagnoses where you're spending $31,000 or $10,000 a year. Now men and women are even. And you see that the senior population drops way back. There's a lot of reasons for this. Could be that the senior population just isn't going to handle that many primary diagnoses and still survive. And there's a lot of things that could be going on. But what you see here is that the state-sponsored business starts to pick up. This is where really sick people end up in Medicare or Medicaid. Okay, and all the while, you can also watch how the age distribution changes. So here, where you're very sick, the primary users here, or the primary spenders, are between 35 and 44. Versus when you're back down to 1, the 18 to 34-year-olds do all the spending. So this is probably less about engagement, but more about just being able to tell a story and answer questions back. And please do ask questions. This is an experiment of some sorts on my part to see how people react before I go and do this. Now, one of the things we did in the sample is we stratified it by always compliant, never compliant, sometimes compliant, and usually compliant. What this means is that if you're always, you're 100%. Every time your doctor tells you to do something, you do it. If you're never compliant, you've never been compliant. You've been asked to do things like refill a prescription, get a test, and you never do it. And in between that are usually, which is 50% up through 99, and sometimes, which is 50% down to 1%. So that's how it works. So you would think, and you might have preconceptions in your mind about who is the least expensive group to work with. So are there any suggestions around who do you think is the least expensive group? Okay, so if you look at the always compliant people, they actually spend a little bit more than the average. And that's the cost of compliance. When someone is absolutely compliant, they're gonna go to the doctor more. They're gonna get that test. And that's a short-term cost that I've run into a lot, where the plan starts to react negatively to that and say, you know, these people are costing us too much money. And I would say, and in longer term studies, that money is well invested. They actually, in the long term, end up spending a lot less. The shocking fact of this group is that the never compliants are the cheapest. And I think that really is passing the buck. Even though they never do anything, they're probably gonna roll up to a larger cost at some point in the future. And in health, there are some problems with that because we're pretty good at passing the buck. I mean, as you age out, you move into a different plan. People change plans all the time.
Because your last bucket there is 74 years old, right?
Right.
So beyond 74, maybe a whole different story.
Exactly. And you really would have to look at them separately, and it's sort of interesting because in that 55 to 64-year-old zone, if you were a plan and you planned on hanging on to them for a significant amount of time, you would want to drive down costs if you were just purely financially motivated. So less tests, less visits to the doctor, things like that. So that's the story for costs.
Did the sometimes compliant have a big jump, or was it from the never to always, was it a linear?
Yeah. So always is 6.6, never 4.0. And then your most expensive groups are the sometimes and usuallys. And I can't explain that. It's really weird how there's certain, and that we're gonna go into this in another visualization, but there are certain combinations of diseases that people are more compliant in, and I mean really in a predictable fashion. Generally, the more sick you get, especially if it involves a liver condition, you're gonna be really compliant when you get that sick. But when you're not so sick, like type 2 diabetes, it's much less average compliance. And then the usuallys are 10.
For how many, that was for one diagnosis?
No, this is all diagnoses. These are just people that fall between 50 and 99% compliant over a range of many different things, in many different, this is amazing generalization. But the message to us in terms of engagement is, why are we contacting the always compliant? They're gonna be always compliant. Why are we reminding them of their perfect compliance? The same is true of the nevers. If there's a demographic of people that are just not gonna work with you, working with them the same way you work, and we talked about that with the Blue Cross of Tennessee people, if you working with them in the same manner you work with the always, you're gonna lose, because you're using the wrong tools to approach them. They're different. They're not gonna react to that stimulus.
And Tim, this is paid claims that we're working with?
Yes,
Okay. So it's not, has nothing to do with contracted fees, it's paid claims.
exactly. Okay. So in terms of engagement, and I mentioned this a second ago, if we look at different disease combinations and your compliance in aggregate, your diagnosis has a lot to do with your willingness to comply. So we see here, the highest one is someone that had coronary heart disease and hypertension. This group has the highest compliance rate of all those people that have been diagnosed. And then if you look at basically, yeah, it's congestive heart failure, they're much lower. And what I'm trying to say here is that these represent groups that you should treat differently, because they perform differently, because they've been diagnosed in these different combinations. And this holds up over a lot of different splits of the data.
And Tim, this is full compliance
Nope. So, for example, people diagnosed with hypertension in this sample are about 50% compliant with the things that they've been asked to do.
Compliant with every,
So with hypertension, if you've been diagnosed, probably a lot of that would be visits and prescriptions.
whether it's not partially compliant or most often they're usually compliant, it's full compliant?
No,
Or am I missing?
for this group, 50% average, okay?
Sorry.
There are some that fall well below the average. COPD and diabetes in general tends to carry with it a lack of compliance. And I think that might have something to do with the way the disease is manifested. You know, that's why you're a type 2 diabetic. You're not typically compliant. So this comes into the power of engaging with the physician. And this is really one of the biggest parts of the story here, is that when you're 0, and keep an eye on the chart right here to the right, the male-female split, women are generally less compliant. That's in this sample, that's how it works. But when you've not been diagnosed with anything, men outstrip women almost double in their compliance. But as your willingness to visit the physician increases, your overall compliance greatly increases. And this is a big lesson for those working with engagement, is that if you can get people into the physician's office, good things start to happen. So at one evaluation and management visit, so a checkup or something having to do with the evaluation or management of your disease, look what happens to the cost. You go down to 1.5 thousand versus the mean of 6.2. That one visit has a huge impact on what you spend and your compliance. And as you climb the ladder for these visits, let's say we go out to 5 visits in that 3-year period, men and women start to even out, and you still haven't spent the average amount of money. That group of people that's willing to get up, make an appointment with a doc, go, is a very special group. And they form, you know, really your best customers. So looking for strategies to set up some shop in the supermarket or get them in front of a doctor really is very powerful. And it's something you should consider doing. Now, one of the cool mixes I discovered on the way, I'll just set this up, is even when you're sick, if you still see the doctor, you're gonna do better than average. So if you add on to that a primary diagnosis, like the ones we were talking about, so coronary heart failure, COPD, diabetes, or hypertension, and you see the doctor regularly, you're still not spending up to the average, even though you're sick. And that, to me, is further power into the discussion around getting people in front of their doctors and the value of doing that. So the next one is a little bit more touchy of a conversation. It's the role of where you live versus how you behave as a health consumer. There's a lot of research done on this, and what I've done is I've taken all of the zip codes in America by median household income, and I stratified them. So a 1 would be the most poverty-stricken zip code, and a 100 would be the richest zip code. And then I mix that data to say who goes to see their doctor for E&M visits across that population. And as you can see, the left-hand side of this graph is largely populated with richer zip codes. These people go to see the doctor more than poorer sides of the graph. And I think there's a couple reasons for that. One, it's not the way we typically communicate. I think health plans tend to communicate upscale. unless we're a specialty, state-sponsored line of business, we tend to go upscale. The imagery and the words are generally aimed at people like those that work in a health plan. I have a graph in a minute that'll further demonstrate this point. But when you compare that to where the actual claims come from, so let's count them, this side of the graph goes away. The wealthy side goes away. We have to slide over and see the poorer side of the graph. So there's many, many more people in less high income zip codes that are using this service, but we are much better at getting the ones on the rich side to go to the doctor than we are on the poor, on average. That's the point I'm trying to make. Then, to further demonstrate the point, if we start to as diagnosis increases, it becomes a more problem for the poor. So if we take our diagnosis count and we put it at 5, look what happens to the left-hand side of the graph. It gets poor. And I really don't know exactly why this is. It's just a fact I'm stating. That 100% through 60% that occupied the left-hand side of the graph goes away. It goes to the other side when you get very ill. And the other thing that goes on, if I reset that, is your age band. So here we are back at the mass of the population, the wealthier zip codes going to the doctor more often. But if I make it kids, you lose that. So again, it's something having to do with the children, on average, in underserved zip codes, not getting the services that they, that adults and more wealthy people get. And if you split it by gender, nothing really happens, which is, I guess, good news. So you look at women are spending about 5.4K in that time period. And then men, spend a little bit more, 8. But the zip codes are about the same. They're still going to the higher frequency in the richer zip codes. Any questions about that? The point I'm trying to make is just that we're talking about segmentation. We're talking about a segment of one, and I think that we're better as an industry going upscale than we are down. So,
Is there anything based on what you're seeing that gives us hints as to how to go downscale?
I think really what it would take would be talking to companies like Molina, that work with underserved populations. And having worked in a corporate marketing department myself, telling all those people to go home, because they all went to college, they all, are, probably more wealthy. You need to get other people in the department that know what it's like, or at least listen to them, and then put it through their lens. I just think that you need to think outside the box, or it could be a different mode of communication. And pop-up stores and things like that are generally more successful.
I
Yes.
think it's a lack of understanding of disparity. What is that? We talked about culture, we're talking about languages, but there's a whole other side to disparity. So, I'm the mom and I have a choice. I can maybe use a home remedy and or the ER, which is not gonna cost me anything if I have to go, because I gotta pay the $10 for the milk and the food. My choice isn't always, something that the wealthier side doesn't have to balance that, right? Or I don't have time to come off of my job, that's the only job I've got, and I won't have money till the end of the month. So if you're telling me I have to put a copay in because I'm still making it barely, so I'm the working poor, right? Cause our health system kind of overshadows Medicaid. Medicaid covers quite a bit. And then when we have our Healthy Michigan in our side, getting the $10 out of, for a family of 10 doesn't always get paid. The premium for $10 doesn't get paid. Why is that, right? And we're all trying to figure that out. So I don't know whether we're gathering that into the data to help us figure out what are the social determinants, the socioeconomic challenges, and how do they play in our messaging? Are we missing a way to connect some of these things? Like, are we going to the food bank? Are we going to, you know, when you go to talk about healthy eating and we say there's an open air market, the coupons, they're going for their, you know, I can get 10 of Kraft macaroni and cheese.
Pop-Tarts, yeah.
Right?
But can you get salad?
And
No.
salad is
No.
much more expensive.
Right.
That bag of salad is much more expensive. So I've been looking at, oh, you can hear, this has been one of the things I've been trying to wrap my head around with the data
Right.
to say, how do I connect to things, you know, we've done 400 events this year out in the community, trying to get them in, and we've had Flint, so I can tell you all the kind of fun stuff we've been having, and it's getting into the house just to put the filter in. And yet they know poison's going in that water. So there's a whole lot of trust in trying to get past that, and I don't know if it's a letter or us writing in the 6th grade, because I can honestly tell you, some people say, you know what, I did go to college, I'm in this circumstance for life effect, right? Not because I can't speak or I, you know, so they get, you're walking a very unique balance socioeconomically. People lost their jobs, they're in a position that they never thought they'd be in, and they're on Medicaid. So I don't know the answer to some of this, but it'd be interesting to see if there's any way to balance your data now and add that layer over it.
It's all in what we collect, you know?
Right.
It's not the stuff we typically collect.
Right, but it's a much harder database.
Yeah. I mean, I agree, and obviously affordability is a factor. Accessibility is also a factor. There are food deserts, right? So there are places that people just can't get to in their community.
Right, it's
for
the liquor
health
store,
reasons.
right?
Liquor store, 7-Eleven, right? So when you're talking about the processed foods, et cetera.
Mhm.
Another thing though I want to add to this is something that I think is an issue, particularly with low-income communities, is health literacy. I think health
Yeah,
literacy
yeah.
is absolutely something that we haven't talked about, I think, today, and I think it's really important.
Well, I think in your presentation, where you've got people on the street, the literacy rate is horrible. Or we're using the wrong words to describe what those things
I
are.
think the fact we call it health literacy is part of the problem.
This is interesting, yeah, this is
Right.
interesting.
Yeah, but we did address this morning the idea of simplifying language, and I think that does address some of that. But there's, you know, the way in which people navigate a system and how hard it is for folks that are perhaps less educated, maybe are immigrants, you know, English, they're not as proficient as we think they are, even though they state that English is the language they prefer. So, I mean, all of these things I think are
So the last myth I want to slay is one I got taken into. So I'll admit, when I first started hearing about ER abusers many years ago, it's like, yeah, those are the people that hang out in front of the hospital, and they're always going into the ER, time and time again. And they look just like this guy. It's really weird. So someone much more enlightened than I at one point said, you know, you should really look at the data, because it's not what you think it is. And the whole industry is driven at going after these, you know, street urchin Bedouins that are in the ER every day. So let's talk about that. So in order to address that, I took Los Angeles, and part of the limitations of these programs is when you put it on a graph, it sucks up amazing amounts of memory and power. So if you take LA, which is a pretty good example of, it's got a nice, in one small area, very poor and very wealthy areas. And you look at ER abuse as defined by the New York, NYU guidelines. It's people that go into the ER for things that really should have been seen by a PCP. This is what LA looks like. So unfortunately, the way this monitor is set up, I can't zoom in, you can zoom in and play with the chart in real life, but not on this tiny little monitor. Let's look at just those underserved areas. So I'm looking at 0 through 7%, which are the poorest zip codes in America. And if you look at the biggest bubble, which means they abuse ER more on average than anyone else, it's the 7% bubble, and they do it about 2.5 times per person in that 3-year period. Now, this unfortunately supports this belief that ER abuse is a poor person thing, which I also wanted to see if I could slay that one, and unfortunately that still stands, at least in LA. I've done parts of Ohio as well, and it stands. If we look at the high end, so we have Westwood, which is ranks in the most affluent part of America, zip code in America. You see the smaller bubbles are in the more affluent areas and down the coast. So imagine in LA, you've got very wealthy areas surrounding the middle of the town, which is generally poor. And this can be really helpful when you mix and match this data for different types of diseases, things like that. We use it all the time for tracking cancer. If you lay over cancer with Superfund sites, you'll get a pretty good correlation. So it's very helpful, and it can be used in a lot of levels. But let's look at this data in a different way. These are people that have abused the ER nationally, and how many times they've abused the ER in that 3-year period. And the first thing you learn is that the vast majority of them only do it once. And that's because there are other reasons there, which I'll get into. But we react to the myth that these people are constantly abusing by going after them. We have models that try to target frequent ER abusers, but what you're doing is sending them a message, stop abusing the ER, when they were never going to do it ever again anyway. And this gets to Neil's point about, we just come in at the worst possible times. So that's a national graph. If you mix it, some other truths start to come out. So look at 500,000 people in this segment abused the ER once. The next step down is 100,000. Yeah.
But that would just say, don't ignore that. It would say some kind of prevention. It's going to be a one-off thing.
Yes.
You got to get the message before, not after the fact.
Sure.
Because if they're only, on average, going to go once, trying to do a campaign that targets them after the fact is a waste of time.
Right. It's
the proverbial horse is out of the barn.
It's an educational opportunity, not a stick.
Prior to.
Right. Then the problem becomes who's going to do it.
Right.
Sure.
But I also think if you're saying, if you define what ER is and why did they go, because we also found people that had certain needs, and the very directive is when you experience X, you're to go to the ER, right? So what are what was the root of why they went?
We're going to get to that.
Okay.
Thank you. So, who is it? Is it 75-year-olds? It's like 30,000. Not too many out of 34 million. 65 through 74? No. 55-year-olds? No, they're pretty good actually. And 45, same thing. But when you go to 18 through 34, when you go to little kids, that's more than half. So it
Parents
involves
taking their kids.
little kids, right? And there's certainly sensitivities around, I'm not going to mess around making an appointment. I'm going.
Yeah.
So maybe there's something there around telehealth along with education. It's a slippery slope, because the second you start telling people not to go to the ER for everything, you know, somebody's not gonna go to the ER and bad things are gonna happen. So there are alternatives. But when you think about this being the prevailing image of who an ER abuser is, compared to the reality, and it really is the reality, because when you're at this large a data set, it's, you know, 34 million speaks very well for the rest of the 300 million statistically. We're at a point where you can say this is pretty much the way it is. So that's just another one I wanted to share in hopefully a dynamic way with you. The last one I did is same thing, but with how people visit the physician for evaluation and maintenance visits. So it's still LA, and what you end up with is the reverse of what ER abuse is. So if you look at the poor populations, again in the center, they're all the little bubbles. And if we just mouse over one, well, it's kind of a mess because there's a lot of zip codes in there. But their average E&M visits in this 6% income rank were 6 in a 3-year period. So if we wipe that out and we scroll down to the wealthy parts, we see again, you've got the Westwood area and the coast covered, and you get very, very large bubbles. One of the biggest ones is Westwood, and they're going, there's an even bigger one. They're going 11 times in that same period. So almost double. And again, I don't know why, but the very fact that this exists, I think speaks to how we're treating these different entities, or these different people, how they consume information. And it may not just be on their wealth alone. This is the data that I have. There could be other things, and you wouldn't want to just jump to a conclusion.
They're taking the kids.
Right. They might have more kids. No, seriously though.
Wait, the wealthy areas took their kids to the ER more than the poor areas
Well,
took their kids to.
So we're in regular physician visits.
Oh, right,
Oh,
yeah,
yeah.
maintenance visits.
Right.
Yeah.
I switched.
Oh, sorry.
So they're taking in for their wellness visits,
Yeah, well,
they're
I-
taking their follow-ups.
I would guess the wellness people have more
sporting.
time off.
Well, it could be that too.
They have a
And then
parent
there's
that's not
access.
working.
Yeah.
Mm.
In the wealth.
It's more of just a thought-provoking statement, and you know, the ER one is more targeted at things that I've heard that I took for granted for years, and until I really looked at it. And I'm sure there are many more. You could make a business out of just exposing healthcare myths.
How do we get this data? Can we have?
No, it's got PHI in it.
The ER visits, was that specifically for California area?
Yeah, no, well,
Oh,
this,
that's out of the 34 million, right?
yeah, this.
So do you have any like summary slides of that?
Yeah,
Not
you're
the
gonna
data
get,
behind it, but-
you're gonna get this. Part of the problem is that, as we all know, the count data has individual level data in it.
Yeah.
So I can't give that out, but you're gonna get all these.
Okay.
And of course, if you have any questions, more than happy to answer.
More of the story we're gonna get, right? Your message.
Yeah, you're gonna get the
Like
flat.
your key insights, your key findings.
Right.
Right.
The- What you won't be able to do is drill into it because you
Yeah,
need the
yeah, yeah,
software. Yeah. Okay. So, question for you though. So, say you're a consumer of our services. You know, is this something that you would want to sit down with somebody with and navigate, or not?
Personally, me, I'd want to, but also add to what you're collecting. I'd wanna drill and with different elements
Okay.
to drive and see where the real root of what my population's doing. Because just to say the rich people take their kids, really, what is it? I would go some more levels down.
Oh, sure. Yeah.
Right? And I'd wanna kind of evaluate, especially in our region, we've got a variety. We've got, you know, the rural, we've got the inner city, and it's all in our mix.
Right.
And so, what things are the challenges? Is it transportation? Is it, you know, the culture of, you know, I work on the farm, we only go when something's broke and fallen off. You know, that's the way we did it, and that's the way we still do it, and how do I get them to say preventative is, that's just wasting money, you know? I mean, there's so many things underneath that I try to see how I can then build a persona of what would resonate with X, and get them to do just a little bit, and if I could just to get them to do a little bit, I've moved a marker. Because I don't think I'm gonna change an entire country's culture right away, I'm not gonna, you know, but if I can just get them to do a little bit of X or Y in a key area, and then have that, you know, story among themselves, because what happens is that they start to talk, like, you know, Bob, I had this, and you know, maybe it means you should take a look, right? And you can't buy that, you can't, no, but you can start the little match
Okay.
and dig towards that.
Right. Thanks, because I'm really not so sold myself. It's like, am I opening a can of worms by allowing clients to do this, or not? Am I answering a need that, you know, because there's the boxes of stuff they don't read. How do we get them to take in the information?
And I think it's just knowing why, that, you know,
Kind of similar to, we try to match up our Google Analytics with our like opinion survey-based feedback and try to get that like quantitative, qualitative comparison going. And I think that's what you're driving at, is that this is missing that, you know, that supporting reasoning for what's
that
going on.
supporting, and I know that it works, because I did that way, 10, 11 years ago with, my informatics guy, when it was, you know, something still new, and we would drill off of CAPS. We would start that to see how, if we all came in as a unit, you know, our case managers, our pharmacists, our frontline staff, our claims, and we'd look at data and say, how are we impacting, you know, with the referrals and all of that kind of stuff. And we would drill to that one key driver and then start initiatives, even all the way down to marketing. So that one of the things was, our first very low-hanging fruit was they didn't believe they could get into our doctor's offices. So we talked our big plan physicians to say, how can I give you an appointment today? Now, we knew most of the time somebody calling in didn't want an appointment right now. They really wanted to plan for it. But when they answered the question, could they get in? What they remembered was, I could have gotten it right now. Right, so it was that kind of, psychology, if you will.
Okay, sure.
To let them know if they really needed to, they could.
Yeah.
For me, I would say, I think it's hugely helpful to be able to sit with the data and cook through with somebody, because often, but it has to be at the right time, so if it's in the beginning of a conversation or idea, and you can have real data that abolish some of the myths that are out there, then that's great, because if not, you have to keep going back, and a month later, you come back with the answer, and by then, execs
They
have gone
forgot.
off and have created a campaign for
Yeah.
the homeless people around ER.
Why don't you tell us that a month ago?
And so the real-time access to data and be able to ask whatever questions that you have of it and get the right answer, to me, is fantastic. Then there's another layer, going deeper to figure out the whys, but that's critical to me.
I think
I
what's
hate waiting.
really, sorry, go ahead.
I was just gonna ask, so I know earlier when Lori was speaking, they kind of extrapolated out what constituted a real emergency room,
Yes.
true emergency, right? So the data that you presented, those were just flat out emergency room visits?
No, it was put through that same filter.
Okay.
NYU has a pretty famous one. And
Okay.
it's probably not perfect, but what they're trying to say is, you really didn't need to go to the emergency room.
So these are ones we validated that weren't necessary?
Yes.
So I know when Neil was speaking earlier, and we went through the track piece, and it talked about, you know, how active were you yesterday, and what did you do? Were you walking, were you running? Did we look at these areas, or do we have like capability within this to say these are pretty active folks, and maybe something aligned with that, or, I mean, are there
Yeah.
other demographics or
Sure.
information that kind of
what I'm forced to do, I'm doing this right now for a diabetes model, is if you look at, there's a government database called the NANES database where they interview people. And they ask them all these great questions, similar to what Neil's asking. But for diabetes, for type 2 diabetes, one of the biggest indicators is how do you feel in general health-wise? And that's not on a claim form. So what we do is we try to synthesize that variable based on your claims experience, which is a very hard thing to do. But basically, if you're on blood pressure meds, hypertension, you've had, lots of traumatic injury for some reason, we would put you in that bucket of saying you probably don't feel too well, and you're more likely to develop diabetes. But I think the smart thing to do would be to just ask them instead of trying to figure it out in a very elaborate way. And no, so to answer your question, activity-wise, you might do pretty well with the purchase data from Axiom. So, they're buying ski trips, and tennis rackets and things like that. That's probably a good indicator that they're active.
So I think one of the interesting things that you've done here is you've taken a large data set and you've got the opportunity to almost invent a new index, if you will, for what it is that patient behavior will be. From a plan perspective, when we look at things like this, we often see people come in with indexes, telling me what healthcare is doing on the whole. Advisory boards made a ton of money doing that. But what would be interesting for us as a plan is to be able to then take this and parse it to our specific population, or maybe a geography to which we're interested in exploring further expansions of our plan, and then seeing how those indexes differ from the whole, because we're inundated with academic literature around, these are the things we see in healthcare, this is what's going on in the ER, we've got these myths that I think you've just, started to disprove or dispel, but what we're missing is how then it concretely could apply to programming on the health plan side to something that's actionable, and I think that's the opportunity you've got here. I think this is really cool.
Yes?
Have you explored America's Health Rankings.org at all?
No.
So anybody can just write down America's Health Rankings.org, but it's something that the United Health Foundation supports, and you can actually go find a state and then move some things around. So I'm not sure if you can pull data out of it to add to this, but
Okay.
It might be another resource just for people to get more data on specific states or the entire nation as a whole.
Okay.
So I don't wanna break this up because you have just proved that data is more powerful than alcohol.
I don't know about that.
That's very rare. I mean, usually people would be, oh, I think we have a reception next door. You can continue asking questions, but we're actually 25 minutes past drinking. So,
They should have brought the drinking in here.
really. So,
Thank
join
you.
us next door.